On the heels of a global pandemic that spotlighted tragic disparities in biomedical research participation and health outcomes, a diverse panel of leaders from across the healthcare spectrum convened on April 22, 2021, to discuss strategies for increasing diversity among participants in healthcare studies underpinning personalized medicine, which depends on inclusive research to inform medical interventions that affect patient populations differently.
The Personalized Medicine Coalition newsletter had a piece by Chris Wells, who's the Vice President of Public Affairs, in which he said, quote, "There is a renewed emphasis on addressing systemic inequities underlying the importance of correcting a lack of diversity among participants in clinical trials for new drugs and vaccines, which leaves patients from underrepresented populations with unanswered questions about how new interventions may work for them. When it comes to personalized medicine, this is a scientific necessity."
Since the early 90s and late 90s, we knew that if you were Hispanic or African American, you were less likely to get a painkiller if you had a broken leg. And that was looking, at existing data and looking at the records. But very often when our data doesn't fit the model, we throw it out. And I think that personalized medicine gives us the idea to think there's not going to be one model. Each person has their own model.
Coming as I do from the medical education perspective, it is impossible to miss the point. Diversity both in medical schools and as a result in the health workforce is clearly not all that it can be and needs to be.
I was an educator in the K-12 setting for almost 20 years. And I ran a school that had a STEM lab, thought I knew everything about STEM, and then joined this industry and realized that I didn't know as much about STEM as I thought. And so I think we need to partner with communities and schools. We need to support teachers. Teachers are busy, but they want their students to pursue science careers.
What we're looking at is developing an organizational culture, developing those shared values and reinforcing outcomes. And this can only happen when we have that commitment from the levels at the top, right up to the president. And it simply has to be integrated into the strategic plan so that it can have the impact and we can monitor the impact on all the relevant metrics that we have within an organization.
How do you address the issues of representation, which is one aspect to it? The issue around development of that talent, because not only do you recruit, but you have to retain and hopefully see these individuals progress. How do we create sort of training mechanisms, which is one challenge that I face particularly in my area as we think about this supply or pipeline of talent that ultimately will come in, at much more junior levels and hopefully progress to senior levels in the organization.
There is clear evidence that racial and ethnic minority communities, underrepresented communities in biomedical research are willing to participate in research. It's the question of how they're accessed. How are they reached out to? Is it with respect? Is it in an intentional way to bring the communities in and individuals in?
I think that patients, like other people in our country right now, are pretty savvy about what their data represents and what that means, including their health data and their protected health information. And I think if we see health technology and these innovations and advancements as ways for people to participate the way that they would in civic life, as a way of kind of being counted and being represented, I think that's a powerful way. One way we can try to communicate that with folks that tend to be underrepresented in our research.
It also starts with the choice of principal investigators. So, frequently we're asked as payers, what kind of data would you like to see? And they talk high level about how many members and maybe ages and others, but we don't frequently see plans for clinical trials that explicitly have targets of having a diverse population included. And again, executing on that, it's not just about having that in the plan, but it means actually choosing clinical trial sites that themselves serve diverse members.
What's missing is logistics hesitancy, because a lot of people are working in jobs where they can't go when they're doing the vaccines and they need to work. There are problems in getting that. And the idea of two shots for some people means losing 2 days of work. So I think that part of it is that how we frame things has to be from the viewpoint of the person that is being served and not from our viewpoint. And that's why personalized medicine is the answer, because it really meets the person where they're at.